Thanks for coming. My name is McLeod. I'm a professor in the philosophy department at Western and one of the organizers of this event. Much of my research deals with conscientious refusals in healthcare, and that's the topic we're going to discuss together tonight. This event is sponsored and funded by the Canadian Institutes of Health Research. This is their massive banner that they couriered to me at much expense, I'm sure. So the CIHR, Canadian Institutes of Health Research, started the Café Scientifique program as a way to get the public together with health researchers to discuss burning questions in health research. So the burning question we're going to talk about tonight is what the Canadian Medical Association's policy should be on conscientious refusals. I want to just say two things about these refusals. One is that they need not concern abortion. We used abortion as an example on the poster, but physicians can refuse to do other things like care for patients who smoke, care for children whose parents refuse to have them vaccinated. They can refuse to abide by laws prohibiting euthanasia. So there's lots of different kinds of refusals that can happen. Also, of course, health professionals other than physicians can make conscientious refusals. Nurses can do that, pharmacists, midwives. And our research is actually, we're interested in those other health professionals as well. But we decided for tonight to narrow things to physicians. But if people want to discuss refusals by other healthcare professionals, we're open to doing that. I just want to make some introductions. First of all, Laurie Cantemir and Patrick Clipsham, if they could stand up. These are two researchers doing work with me on conscientious refusals, and they were enormously helpful in organizing this event. It wouldn't happen if it weren't for them, mainly because I'm on parental leave and I didn't have time to do this stuff. So they're going to help out tonight too by passing around wireless microphones. We've got two of them, and also they'll chime in if they feel it's necessary. And of course, I want to introduce our speakers. We have a panel of 3 speakers, and they come from different disciplines, from law, medicine and bioethics, and from theology. And I'm really thankful for their participation. 2 of them flew here all the way from Halifax, which is lovely. So the first speaker is Professor Jocelyn Downey, who's a professor and Canadian Research Chair in Canada Research Chair in Law and Medicine at Dalhousie University. She's published in a wide range of topics in health law and policy, including on euthanasia and abortion. And she's really been a central figure in policy debates that have gone on recently about what the CMA policy should be about conscientious refusals. Our second speaker is Father Michael Prieur. Whenever I move away from the mic, I'm lost. He is a professor of moral and sacramental theology at St. Peter's Seminary in London. He may be known to many of us here. He's been very influential in discussions about health policy in London. He's written numerous bioethical position papers for St. Joe's Healthcare in London, and he's also a consultant for the Catholic Health Alliance of Canada in Ottawa. And our third speaker is Dr. Robin McQuarrie. Am I saying that right, Robin? McQuarrie, who is a PhD candidate in bioethics and also a 5th-year resident in obstetrics and gynecology at Dalhousie University. So she's just finishing up her residency. She does have a special interest in conscientious refusals in medicine, but her own research deals with a different topic, with the inclusion of pregnant women in clinical trials, and also with the delivery of obstetrical care for Canada's Aboriginal population. So those are our speakers, and you'll hear more from them. You'll hear something from them in a moment. But before we go to them, I want to say something about the format for the evening. We're going to give each speaker 5 to 10 minutes to to make about sort of 3 core points at the beginning, and we'll just go through them one after the other. And then we're going to have just a short break, to allow for some informal discussion if you want to talk to friends you're with, people at your table about what the speaker said. Also, if you want to get some cake and coffee or whatever, there's a chance to do that then. And then we're going to reconvene and have a more formal discussion that I will moderate. And you'll just raise your hand if you have a question or you want to participate in the discussion. One thing I want to say about that portion of the evening is that we want to generate a real discussion rather than just have a question and answer period, as if these people at the front are the only ones who have something meaningful to contribute to the debate. We expect everyone has something interesting to contribute. And we just might throw back questions at you. If you ask us one, we might say, well, what do you think? To try and generate a real debate. Okay. Just one point about sort of the ground rules. This is quite a controversial issue. I've been working on it for a number of years and know that people can disagree quite strongly about it. So we just want everyone to keep in mind that it is controversial and reasonable. People can disagree about what the policy should be. We just want everyone to be friendly. One last thing before we turn to our speakers. If you have any suggestions for future cafes Scientifique, we might put in a proposal to do another one in a year or so. Please give us your suggestions. There's paper over there where you can do that at the end of the evening. And also, if you'd like to be emailed about a future cafe that we might run, then please give us your email address. So I'm just going to turn it over then to our first speaker, who's Professor Jocelyn Downey. Thanks.
Thanks, Carolyn. Thanks for coming out this evening. I hope that we're going to have a very lively conversation about a really important but very difficult topic. So let's see how we do this at the end. As Carolyn said, we're here tonight to talk about the Canadian Medical Association policy, the CMA policy, on conscientious objection. I think we'll say objection and refusal fairly inconsistently, but we're generally doing the same thing. And really the question is, should physicians be permitted to refuse to provide information, to provide referrals, to provide treatment or other forms of services? So for example, Carolyn mentioned abortion. We also might talk about access to new reproductive technologies, might talk about assisted suicide. There are lots of things that people might have an objection to that we need to consider. Now, before the others and all of you get into the discussion of the question, what should the policy be? My role is to lay a bit of a foundation. So I'm going to say a few words about why it matters what the CMA policy on this is, and what is it? Because you can't really get into what it ought to be unless you know what it already is. So first off, why does it matter? Now, the question on why the CMA policy on conscientious refusal matters can best be illustrated through a discussion of a specific issue. You can't just sort of say, well, it matters in general. It's a little easier to see something very concrete, and I am going to use abortion as the example, because it very acutely illustrates why it matters what the CMA says on this. We have a really serious problem with respect to access to abortion in Canada. Now, that may surprise some people, because a lot of us assume that in Canada, in contrast to the United States, women's access to abortion it's enshrined in law, it's guaranteed by our healthcare system, everybody has access. But that is simply not true. In the 60s, the Canadian physicians and the Canadian women's movement, echoing here, fought against the prohibition of abortion in the criminal code. It was flat out prohibited. They had a big fight and they won. So they got it changed. They were somewhat successful. Parliament modified the law and allowed some abortion in circumstances where it was approved by a therapeutic abortion committee. That was the state of affairs for a while, and Henry Morgenthaler, a name familiar to most of you, then took on the fight and was providing abortions without these therapeutic abortion committees. And he was charged, and his case went all the way up to the Supreme Court of Canada, and the Supreme Court of Canada struck down the provisions in the criminal code because it said the delays that are created by these therapeutic abortion committees violate women's rights. And they struck it out of the criminal code. And we then were left with no law. That's the peculiar state we're in. We don't have a criminal law. So you think, okay, we won, then it's fine. Abortion's available to everybody, but not so. There are huge problems with access, and they're particularly problematic for disadvantaged women. So Teenage girls, particularly those who are poor, live in rural areas, are young, disabled, Aboriginal, interracial minority, immigrants, don't speak English or French. In other words, those who are most vulnerable don't have access to abortion. In some provinces, abortions are not available at all. PEI, you have to come over to Halifax if you're in Prince Edward Island. Only 17.8% of all general hospitals offer abortions. Less than 20% of hospitals offer abortions in Canada. And if you are going to go to a clinic, because there are some clinics, Morgan Taller clinics around, we're talking $500 to $750. Well, that's a prohibitive amount for a lot of women. Some hospitals require physician referrals for abortion. New Brunswick, you have to have 2 physician referrals to get one. Some have waiting periods of up to 6 weeks and post-gestational limits. There are all kinds of things that are going on. And now we get to the crux of it. Some physicians simply refuse to provide abortion services at all. Some refuse to provide information to women about where they can get it, even if they're not going to give it. They refuse to provide referrals to services. Some give misleading information. They tell women, you can't have one, you're at 10 weeks, yeah, that's too late for an abortion. They deliberately mislead. Some give unsolicited anti-abortion counseling, and they frame it in terms of conscience. So physicians play a really important role. They're a gatekeeping role. It's a rate-limiting role on access to abortion. So if conscientious objection is permitted, women's access to abortion is limited. That's why it matters. So what is the policy? The Canadian Medical Association Code of Ethics, the broad document, has some provisions that are relevant to the issue of conscientious objection across the full range of issues that we're talking about: euthanasia, blood transfusion, reproductive technologies, and abortion. It says things like, consider first the well-being of the patient. That's the first statement in the Code of Ethics. What does that tell you about what you should be doing? Recognize and disclose conflicts of interest that arise in the course of your professional duties and activities, and resolve them in the best interests of your patient. In providing medical service, do not discriminate. Inform your patient when your personal values would influence the recommendation or practice of any medical procedure that the patient needs or wants. There's a duty to provide whatever appropriate assistance you can to any person with an urgent need for medical care. You have to provide patients with information. So that's all heading in one direction, but you also see, having accepted professional responsibility for a patient, continue to provide services until they are no longer required or wanted, until another suitable physician has assumed responsibility for the patient, or until the patient has been given reasonable notice that you intend to terminate the relationship. So you're starting to see a hint of allowing conscientious objection. But these things are all really quite general. And when push comes to shove, and indeed in these areas it comes to shove, they don't give you enough guidance. You know, poor Robin, she confronts a situation, she goes, looks at the Code of Ethics, what's she supposed to do? It's so general, it doesn't really tell you what to do. So you might think, okay, let's look at more specific policies and see what they tell us. So here we look at the CMA policy on induced abortion, because it's the specific one they have that may take us in, and we can say, okay, well, what do they say about conscientious objection? And then we could extrapolate out to other kinds of issues that people object to. I think that the current CMA policy says that a physician who sets up barriers to prevent women from accessing abortion violates CMA policy. And a physician who doesn't provide assistance in accessing abortion, so for instance providing referrals, in some circumstances I think violates the abortion policy. Here's why. The policy makes the following statements. It says a physician should not be compelled to participate in the termination of pregnancy. Well, there you're allowed to. There's conscientious objection. No discrimination should be directed against doctors who do not perform or assist at induced abortions. Respect for the right of personal decision in this area must be stressed, particularly for doctors training in obstetrics and gynecology and anesthesia. Strong statements for conscientious objection. But it also states, a physician whose moral or religious beliefs prevent him or her from recommending or performing an abortion should inform the patient of this so that she may consult another physician, starting to limit it. And the patient should be provided with the option of full and immediate counseling services in the event of unwanted pregnancy. So start again limiting. Since the risks of complications of induced abortion are lowest in early pregnancy, early diagnosis of pregnancy and determination of appropriate management should be encouraged. And, this one's key, there should be no delay in the provision of abortion services. So I think the CMA policy means the following. If the exercise of the physician's conscience with respect to the provision of abortion services, including referral, would involve no delay, then the physician can exercise conscientious objection, refuse to provide the services. But if the exercise of the physician's conscience with respect to the provision of abortion services, including referrals, would involve a delay, then the physician may not exercise them and must provide the services. And given the egregious shortage we have of family physicians and other kinds of healthcare providers in Canada right now, a refusal to provide a referral will very often cause a delay, if not an outright barrier, an absolute barrier to the patient. So I think the burden of proof flips to the physician who wants to exercise conscientious objection to show that there's no delay. In my doing this, there is no delay. And if they can't do that, then they have an obligation to provide. Now, before I pass the baton over to the others, I have to flag for you, big flashing red lights, people disagree with me on this interpretation of the policy, including the Executive Director of the Ethics Office of the Canadian Medical Association. I think he's wrong, but he thinks I'm wrong. When Sandra Rogers, who's the former Dean of Law at the University of Ottawa, and I wrote a guest editorial in the Canadian Medical Association Journal on this topic, a firestorm erupted. So much so that the CMAJ eventually said, we're not publishing any more letters on this. So much so that the co-chairs of the Pro-Life Caucus in Parliament in Ottawa wrote to Sandra and my deans and told them to take the necessary steps to shut us down. The point here is not whether we were right or not. I'm setting it up as this conflict, but the point is that the CMA policy on conscientious objection about abortion, and arguably about other kinds of interventions and information, it clearly needs to be clarified, given that it can be taken to such seemingly disparate conclusions. I can say one thing and the head of the ethics office says something completely different. Well, clearly it's not clear. And you need clear policy when you're talking about whether physicians can, and you can take this to the other professions too in their policies, whether they can refuse. So I think the lesson is the abortion policy is unclear. We extrapolate it out to the general policy with respect to all the various interventions. It's unclear, so I'd argue it has to be clarified. So the question is, if it has to be clarified, what should it say? What should the CMA policy on conscientious refusal be? And now I get to duck out and leave the hard work for Father Peter and Robin. Should it be?
Well, thank you very much, Jocelyn, for setting forth the parameters. And throwing the gauntlet down, and away we go. So that's helpful for us. Well, I'm happy to be here tonight. It's new for me, this type of a game. First of all, I thought everybody would be 3 seats and win and the 4th one flying by this time, but I see there's nothing alcohol yet, so I'm much relieved. I thought tonight all I can do is set up a few parameters. I was a Catholic theologian. I told him before we had our little meeting, we deal in centuries, so there might be a few things from the centuries that might help us just to get some ideas and parameters here. I learned actually the whole question of conscientious objection started in the 1890s with mandatory vaccinations. And that's been got the ball rolling with the concept. Although in our tradition, the concept goes way back in terms of war. I'm not going to cover war tonight, but there's where really the huge issues, the just war theory, and so you get right back to the Christians refusing to become soldiers in the early centuries, St. Augustine articulating a just war theory policy and climate modifying it, all of that. So there's a huge tradition there in terms of conscientious objection. In the medical field, though, the vaccination thing, I think, where it became acute. Well, with that in mind, I just simply want to give you a few thoughts in terms of the whole question of conscience. Conscientious involves conscience, and from a perspective of our understanding of conscience, really, it's a real internal law. It's not self-imposed, but it's written in our hearts and souls. You can say by God Himself. Everybody's got a conscience. No matter if you're a believer or not in God, there's still kind of a moral compass in us as a human person. And that's because we're spiritual. And so we have spiritual values. So we're not just atoms, we're spiritual. So we do have a conscience. And that takes priority, that conscience. And that can supersede any human institutional laws. So there is a kind of a fundamental ground for conscientious objection is rooted in the fact that we have a conscience that has to be followed. Even the great St. Thomas Aquinas had this statement: it's wrong for one to make an act of faith in Christ if in one's conscience one is convinced, however absurdly, that it's wrong to carry out such an act. So we have to follow our conscience. It's the last arbiter we have in our human existence. John Henry Cardinal Newman was a big defender of that. The whole aspect of following our conscience, that can go even above authority. So we'll say that conscience is our sanctuary, our most sacred core, where we find ourselves alone with God, His voice resounds with us. That's our statement on conscience. And so the bottom line, we have to obey God rather than human beings. And this is for a believer, but even a person who isn't a believer still has to run with what he or she thinks is right. Remember St. Thomas More, I'm the king's good servant, but God's first. Chop, chop. So, fight for that one. So really, this conscience dimension is a powerful dimension in human beings, if that's really where they're at. Now you can have erroneous conscience, false conscience, different kinds of consciences. That's part of understanding what we mean by that. The United Nations recognizes this. Their Universal Declaration of Human Rights in 1948. Every human being has the granted right to freedom of thinking, conscience, and religion, and the right for work, free choice of professions, and suitable working conditions. So right in the Chartered Rights of the United Nations, that fundamentally thinks of what a person feels they have to do in conscience. Well, we know where the rub is going to come. We're going to have to debate this. A physician could be called on by the state to inject a lethal injection for a death sentence, for example. Suppose the physician said, no, I can't do that. We're ordering you to do that. Or a medical intern refusing graduation unless they prescribe abortion as a medical option. These are questions that face us today. So we have to get to that well-formed conscience and moral order where we stand on that. So we're into questions now of personal conscience, freedom, liberty, and what authority laws have. These are bigger issues now. So we can argue about human law, divine law, natural law. These are different kinds of law. We'll also argue, as a Catholic theologian, I find no problem with that, arguing to natural law, the use of reason to discover how we should act as humans. We don't need to believe in God to argue that way, that we all have this moral compass in us, but it's to refine it and to see what is truly good for our humanity. So these are parameters in this question that you just can't get around when you start talking about it. I'm simply going to finish my little presentation on something that I did share with the committee that came out from the Council of Europe in October. And I was surprised to see this. But our very question came up at the Parliamentary Assembly of the Council of Europe. And what they did, they decided to uphold the right to conscientious objection of medical practitioners when this right was being challenged by Christine McLeod, who was a British politician, and She was proposing a resolution calling for the abolishment of the right of medical staff to deny referring women for abortion. And she wrote a report called the Women's Access to Lawful Medical Care, the problem of unregulated use of conscientious objection. And that was submitted to the Parliamentary Assembly for debate and vote. What happened was the European Centre for Law and Justice called a historic reversal. The proposal was replaced with a new text, and the title was The Right to Conscientious Objection in Lawful Medical Care. And the affirmative medical promoted that right. Now, simply put, what they were saying in the McCaffrey report was an aberration. We are delighted that a large majority of deputies are poised to defend the values on which this council is founded: respect of liberty, of conscience, and of life. And they went on to say, the independence of science and of medicine is also an essential value at the heart of democracies. So the Centre said the new text is this: no one hospital, institution, or person may be subject to pressures or held liable or suffer discrimination of any kind for refusing to perform, allow, or assist an abortion, miscarriage, or induced euthanasia, or for refusing to perform any intervention to cause the death of fetus or embryo, whatever the reasons. That's a remarkable statement that they espouse in Europe. And so they want the member states to develop regulations to guarantee this right. So the moral grounds to conclude this little piece, because it's so current, the McCaffrey report was defeated because its primary objective was not only practical but also profoundly symbolic. Effectively, it would have a bearing on the moral qualification of abortion, euthanasia, and of the exercise of the conscience. The right to abortion or euthanasia would become the rule. Conscientious objection would become the exception. That's right, right? So they say. To reduce the fundamental right of moral objection to a mere exception amounts to a reversal in the moral relationship between abortion and euthanasia and conscientious objection. Conscientious objection would become in some way immoral because it's contrary to the right to abortion. Turn right around in their decision. I've never seen this. So finally, they make a good statement here. Practicing good medicine is a moral activity and not just a technical one. The foundational values of medicine are part of physicians' understanding of who they are, and they have provided the basis for historical codes of medical ethics, such as the Hippocratic Oath, the Declaration of Geneva, and the United Kingdom General Medical Council's Good Medical Practice. I brought that today because I thought, currently, getting this passed in October, so that's where Europe is going on this issue of conscientious objection. I think I've given a few thoughts anyway that we're trying to bump and see where we go on this vexing question. Thank you.
I was really excited to be invited to speak tonight. And I'm sort of speaking with two different hats, but as you all know, I'm a resident in obstetrics and gynecology. And one of the reasons I chose to pursue another career in ethics is because in my discipline, we certainly have a lot of ethical conundrums. And we know that women's health care is an area where a lot of the conscientious refusals or conscientious objections are centered around. And I think they've been handled in a couple different ways. So I just want to, we all know the abortion issue. One of the things that I think has come out recently where care has been creative in circumventing the ability to conscientiously object or refuse is the delivery of products like Plan B without a physician's prescription. So when you're looking at issues like this, I think you have to argue that physicians are in a very special position where they have power. And many people argue that physicians don't have, special power, but they kind of do in being the gatekeepers. So I'm going to speak a little bit about getting into medicine and what people need to be thinking about in pursuing a career in medicine. So starting with choosing to be a physician is a voluntary choice. And the choices are many beyond that point. So choosing to take care of patients rather than doing clinical research, rather than working in a specialty where you're not interacting with patients. So that's another choice. So you choose to go into medicine, you choose which medical school you're going to go to, you choose what specialty you will do. And all along that pathway, I think you have to take your personal values into play. So I think, so these are, I'm making a lot of I think and I believe, so I'm going to get myself in trouble up here. But all along the way, you have the choice to pursue a career that doesn't go against your personal beliefs. I know once I finished medical school, I took an oath to do no harm. The most important thing was to do no harm. And I would argue that a lot of times making choices from a position of power to conscientiously object is just by simply saying, I'm not going to provide this service for you, is potentially doing harm to somebody who might be easily influenced, somebody who might revere physicians and think they're an honorable profession. I know not everybody feels that way, but there are some people out there who would feel that the opinion of a physician might impact them. So I think all along the way you have the choice to not get yourself into a position where you have to object. And so I would almost argue that although, as Jocelyn went over all the areas of the CMA Code of Ethics where, you know, there's sort of entries into conscientious objection, the reason that it repeatedly states in the best interest of the patient is because all along the way there were choices that would avoid being in that situation. Now, an argument might be new technologies have developed, and I think that's certainly true, but I don't think that would be the vast majority of cases in which conscientious objection come up. So another thing that I dealt with a lot in medical school, and I think from now on in medical school, is the type of care we deliver. It's no longer acceptable to deliver paternalistic care to patients. So it's no longer okay to say, so I looked at your labs and you should have surgery. You just don't do that anymore. We almost to a flaw, I would argue, provide patients with a list of options, like it's multiple choice, and say, these are your 4 options, pick one. And we refuse to answer questions like, what would you do? What do you think I should do? What's in my best interests? I would argue that you've got probably 10 years of training on the person sitting in front of you, and you might be able to help them. You shouldn't say you must do this, but you're obliged to tell them all the options. So it wouldn't be reasonable for me, because I'm looking at someone and living in the Maritimes, I'm often tempted to not offer surgery because I know it's going to make a bad day at work for me. It's not an option to not offer that patient surgery if it's the appropriate method for them. The same way it wouldn't be if you say you don't like the drug rep for a certain drug company. It's not an option to not counsel the patient on that drug if it's one of the reasonable options for them. Now, as I listened to Jocelyn going over the CMA Code of Ethics and interpreting it myself, it repeatedly says a physician must not be forced to do. And I don't think there's a physician in Canada who has been forced to do anything that is not in keeping with their personal set of values. But I would argue you might be responsible to inform your patient of all the options. And I think that doesn't mean you condone it. It means you're responsible for informing patients. I work in a clinical environment in which access to abortions is particularly limited. I've worked in a province in which it requires 2 signatures, and I've definitely seen how it impacts care, and I certainly would say that in meeting with my colleagues across the country in obstetrics and gynecology, the perception that abortion is freely available to everybody is certainly there, which I think does the cause a disservice, because everybody perceives it to be readily available to everybody, but I can assure you it's truly not readily available to everybody. So then I'm going to have people that are going to argue and say, you know what, I have a right to a career. I have a right to pursue any career I want, and I'm particularly interested in this field in which there's controversial conflicts, but that's my right. Well, I would argue that a person who has epilepsy might have a right to a career as a pilot, but they're not going to be able to do that career because they could cause harm. And so I would say that if you're choosing to enter a profession in which you're then going to do harm to people by not informing them, that would fall under that same category. In particular, women's health care, this issue comes up. But I guess I want to challenge people by thinking about a couple of other options. Because I think it's certainly almost considered acceptable in some realms for a physician to say, particularly on the issue of abortion or Plan B, I'm not going to counsel you on this because I don't believe in it, which I do think is casting judgment to the patient. But I think that women's health care isn't the only issue that this occurs in, but for some reason it's a special area in which it's okay to conscientiously object. I think pretty much if I did a survey of the room, nobody would think that it's okay for a person who is not interested in blood transfusions for religious purposes to not transfuse a surgical patient. They were a surgeon. They said, well, no, I wouldn't want blood, so I'm going to let this person bleed out. I don't think there's somebody here who would think that'd be a reasonable course of action. But I think there's actually a lot more similarities. It's a drastic comparison. But to not offer someone a service because you wouldn't choose it for yourself is not in any way putting the patient's care first.
Great. So you get a sense from these speakers how people might disagree about this issue. So we're going to take a short break, as I mentioned, and go have some coffee and cake if you'd like, and talk with your neighbor and think about what you might want to discuss with the panel. Thanks. So I want to open it up and see if someone wants to start us off for this part of the discussion and make a comment or ask a question. Don't be shy. And again, Lori and Patrick are wandering around with microphones now. Thanks.
I don't know who wants to answer this. So we've talked about conscientious objection. And I'm wondering about your views on conscientious proactivity. Is there a case to be made when a physician in very good, clear conscience can step over the line of either a rule or a law?
So can I just maybe clarify? I mean, do you mean step over the line and actually try to prevent certain activity from happening? I mean, do more than just refuse to perform a service?
Now, what I'm talking about is being proactive, and the example that might come to mind would be euthanasia, for example.
Okay. You want to maybe take that? Jocelyn's written a book on euthanasia, so maybe, not about that, but anyway.
Well, one of the things that I pitch back to you and to the group is to think about the difference between, it's getting a lot of reverb. Oh, here we go. Okay, it's the code. It's the question of conscientious objection, conscientious refusal, and civil disobedience. Because in the context of euthanasia and assisted suicide, I can see if I were a physician, and I happen to believe that euthanasia and assisted suicide should be legal, so I think the law is wrong. I would tend to think of my going ahead and assisting someone as an act of civil disobedience. And it's me saying I think it's wrong, and I am prepared to bear the consequences of it because I believe that civil disobedience has a potential, it has a capacity for transforming the law. Because you get the attention, you have the trial, you have the public discussion and all that kind of thing. So I wonder whether what you're calling conscientious proactivity is a form of civil disobedience. And I actually think there's room for us, as we reflect on conscientious refusal, to think more about the concept of civil disobedience and so on, because one of the things that it does is it forces us to accept responsibility for standing up against the law and being willing to take the consequences of breaking the law. And conscientious objection, on the other hand, refusal, that doesn't tend to be a part of the conversation. And yet it is with civil disobedience. And for me, not surprisingly, coming from a law context, I tend to believe, I think the law can be wrong. But the way to change it is you work for law reform, either by lobbying the politicians trying to get a change, or by taking cases, or by engaging in civil disobedience and doing it publicly, actively, and accepting the consequences. So I don't know if others have thoughts on the way those concepts interplay.
I was going to ask a related question. That sounds really loud to me. I can't tell if it's loud to all of you. So even if you'd agree that somebody has a right to conscientious objection and not to perform certain services, does that right entail also and to accept whatever the consequences are? So you're a doctor, you're the only doctor in this hospital that can provide this service, and you refuse. And I might say, yeah, you have the right to do that. But the consequence is you're fired, and that's a completely just consequence, and you should be able to stand and bear it too, just like you would in the case of civil disobedience. Or is that somehow a violation of your rights that you take responsibility for your action in this way? Assuming there's a reasonable, when you were hired, it was reasonably assumed that you would be able to do this kind of service, and maybe it was explicit. So can you say, is it consistent to say you have a right to refuse to do this, and you also have an obligation to accept the consequence if this is a condition of your job, which is you're fired and you need to find a new one?
Maybe I'll comment and then pass it over to one of you. From the legal perspective, one of the things you described is if you're in a job, and if you had a contract, then what you do in signing a contract is circumscribe your rights. So even if you want to say, oh, you have a right to refuse, well, not when you sign a contract that says the terms of your employment are you do X, Y, and Z. And an employer is allowed to say, these are the terms of your contract. This is what the job is. If you don't want it, don't take the job. Now, there's a limit on that in the sense that an employer is not allowed to tell you to do something and to not accommodate you insofar as it's reasonable to accommodate. So you accommodate conscience, and it's called a bona fide occupational requirement. If you can show that it's a bona fide occupational requirement, we cannot accommodate 90% of our medical staff saying we won't do this and still meet our obligations to the community as a hospital. We would be allowed to force employees to perform certain tasks that are legal tasks, by the way. That's the other piece of it, right? These are legal services we're talking about, whether it's abortion, not euthanasia. You can't force anybody to do something that's illegal. You can't get that out right up front. But the blood transfusions, a refusal of treatment, excuse me, a demand for resuscitation, all these things, abortion, they're all legal. So in an employment context, you actually can, in certain circumstances, force somebody to do it. And nobody would say there's a violation of your rights because you took the job. But there's a lot of, why it gets complicated in health is a lot of physicians are not on contract. And this is why you often see a difference between the way nurses are treated and respiratory therapists and so on versus physicians, because nurses, respiratory techs, physios, they're on contract, and so can be termed the contract, and you can be fired if you don't do it. Physicians, the whole weird way they're all employed, it's a different relationship, and so you have to do a different kind of analysis. Did you want to stand in the phone?
There's a special cone here. But my only point is, we're all talking about rights, and you can't break the law, but then is the law moral? That's a deeper question, of course. What are we dealing with? And so, if you're being asked to do something that is immoral in your conscience now by a higher law, let's say to take life, innocent life, well, you got a big problem. And yet you want to be a physician, though. You want to be a physician. You want to work in obstetrics, perinatology, end-of-life issues. Profoundly convinced that's a good thing. And yet, are people going to force you to take innocent life when you feel that's wrong? And so now you're faced with what I talked about, the classic thing about, wait a minute, this is not a just law that allows innocent life to be taken. right back to a very fundamental issue now. Can I do that? Now, you're right. You might have to get out of the field, but you might want to be proactive too. You might want to stay in the field and say, does this law have to be what it is? Can it change? Or can we get a law in Canada regarding abortion when we have no law, sad to say? So,
So the only caveat I would say to that for non-physicians in the room is that I think the difference is whether or not it's life-threatening. Because the first thing, which also might be scary for people who are doctors here to know, is that the first thing we're taught is to call for help. So if you're in a situation where you are not qualified to provide that service, you call for help. You call wherever you can call. And if you're in it happens to us all the time. We're in a surgery and it gets money, and we just call for more people. Just keep them coming in. So if you're saying, nope, it's Tuesday at 2 and it's not a life-threatening emergency, I just don't want to do that. But that's part of your, I don't know the legalities of whether or not you can be fired, but I don't think you're doing a good job as that person's physician if you're the only person who can provide that service to them. But maybe you're not wrong if you say, you know what, it's Tuesday at 2, so-and-so's working, and I know they're available. I think you need to make provisions, and if it's an emergency, you got to do it.
I'm just wondering if anyone knows what lengths hospitals have gone to ensure that their hospitals are always equipped with, somebody to provide these services. So I know some pharmacies have made it the case that if there's a pharmacist who conscientiously objects to Plan B, let's say, that they always have another pharmacist who doesn't refuse, working at the same time. So what sort of responsibilities are placed on hospitals or other institutions?
They haven't been doing a good job. 17.8% of hospitals provide abortion services. So the other 80+% are not making sure that they have. Now, some of them wouldn't need to. You have certain kinds of hospitals that obviously abortion's not a big driver. But the thing is, the one key piece to remember is that institutions do not have a protected right of conscience. We have freedom of conscience. We have freedom of religion as individuals. We have freedom of conscience. But institutions do not have that. And so institutions, in fact, do have an obligation to do what you're saying, which is to make sure there is somebody available to do it. The problem is a lot of them just can't because they can't get people who are willing to do it. So you have in Prince Edward Island, I believe, 11 obstetricians and gynecologists and zero perform abortion. So it's a matter also of the will to force the issue. Because yes, it's true, they're not employees, and so you can't fire them for not doing it. But physicians have duties that come from other places. So it's not from their employment contract, but it's from, they're in what's called a fiduciary relationship with patients. That creates obligations. There are duties that come from just common law and negligence. You can't abandon patients. That's just a duty from the court system. So there are lots of duties, but somebody has to be willing to enforce it. And part of the problem is that we can't get the state to promote women's access to abortion services. So I think that they'd be on strong legal footing to make hospitals do different things, do things differently, and make sure they always have someone on, the same way with the pharmacists. The pharmacies do. Pharmacy's been much more active in this arena, in part because of Plan B. And a lot of the colleges, I think every college in the country has a policy on conscientious refusal and a whole process you have to go through. They're different in different places, but you have to notify, whether you have to post a sign, and that you have to have somebody always on site who is willing to do it. And it's been quite active, and there's been some litigation around it too. So it's interesting to see too. And part of that, I speculate, is about power. Pharmacists actually have less power than physicians. And so people will take them on
a way that they won't take on positions when they don't provide the services.
I just wanted to ask a question related to a point that Jocelyn made, but this issue of institutional conscience. Because institutions do have conscience protection in some states in the United States. And my question is really for Father Prieur. I wondered if that makes sense to you at all, that notion that a hospital could have a conscience and could conscientiously object.
I think it can. I think there is such a thing as an institutional or a corporate conscience. In fact, the two Catholic hospitals in our diocese, St. Joe's Healthcare Center and Chatham Alliance, St. Joseph's Chatham Alliance, those are the two. They're now under what's called a society, which is a juridical person in church law. A juridical person. And a juridical person, you could truly argue, has a conscience because you deal in, when you get into the area of cooperation, is there such a thing as institutional moral cooperation? And there is. That traditional category of moral theology has always been a personal thing, cooperating evil, and formal or material cooperation. Formal means you agree with the action, you go along with it, you help to bring it done. Material, you don't agree with it, but you tolerate it. We use that. Complicity is the legal term. So, in moral theology, we use those categories of cooperation. Well, hospital as an institution is a cooperator in terms of what we allow or don't allow. And many physicians say, never forget, Sister Mary Doyle, when she was the CEO at St. Michael, Dr. Copeland would say, Sister, this is your house. You abide by what the rules of your house are. It's a Catholic hospital. He was very deferential to Sister Mary because of the Catholic hospital. This was a top-rate obstetrician. So, that question of an institutional conscience, which I think we kick around here, I think is a legitimate concept. It's also coming up in the area now of organizational ethics. This is a new area in bioethics now, more from the clinical, the whole organizational thing. A lot of new writing on this now, organizational ethics. And we've been talking about a lot of that lately at St. Joe. So, conscience kicks in. Now you get all kinds of things like fraud, deception, safety, enormous questions. But there are such things as thou shalt not steal. Simple thing, but there it is. That's what kicks in.
Thank you. I was just wondering if I could follow up on the institutional conscience point. So I'm just wondering where you might think the harm lies when an institution's conscience is violated somehow. So think with an individual, if they go against their conscience, there's some personal harm to the individual. And I'm wondering when you've got a collective of persons or maybe just sort of a corporate constitution of some sort that's been violated, established by the predecessor or something, where's the harm if the conscience is violated? Or where might it be?
I'll give you an example of that right away. We've been pilloried by a particular net on the net as to doing direct abortion. We do early induction. It's a very complicated thing. It's when a mother, is seriously compromised in the pregnancy, the baby is dying, and when can you bring the baby out? That's the bottom line. And we've been accused of doing direct abortions. They're not direct abortions. They're premature deliveries. And so when there's a severe medical indication about a mother or a child, and we've got a policy on that, we've gone to war on this one, all the way back to Rome. So institutional conscience affects us. Wait a minute, we are not doing direct abortion when we do early induction for lethal fetal anomalies. So that's a specific case where this whole concept kicks in spades.
I guess I have a question for Father Prieur, but then kind of for everybody, because Father Prieur was the one who really concentrated on the notion of conscience, and it's now we're going down this road of discussing conscience. And it was interesting that Father Prieur began with a traditional view of conscience that's rooted in the Catholic tradition, and I think we have to admit that beginning with such a view of conscience is going to color the debate in a certain way. This is from, somebody might say that that's a perspective on the debate, others might say that's a spin on the debate that sets it up, that colors it, that favors perhaps the conscientious objector too much, because you've set it up in such a way that an eternal law is, we're being asked to violate an eternal law, and that's something that people are going to probably want to debate. They're going to say, well, we can't have discussion of eternal law in the public sphere. That's a religious notion that has to be kept separate. So I wonder if you believe that you could use the same argument, that you could talk about conscience in such a way that would maybe be more acceptable in a public debate, because I think that, or do you believe that no, my definition of conscience, my understanding of conscience should be acceptable to everybody? So that would be my question to you, but then, Mike, I would just be fascinated to hear what people think conscience is, because I think that there's been a break with tradition, and I think it happened sometime in the 17th century. René Descartes he changed the word. It used to be a moral term. Conscience was a moral term. It got a new definition in all the dictionaries at the time. It meant consciousness. And so conscience went from not being strictly moral to now being something very internal. It's your sort of thought, your very personal thought. So it went from being something bigger than you to just being something that occupies the space in your skull. And so now that there's been this break with the tradition that you mentioned, people have a lot of freedom to invent theories of conscience, use them in this debate, and spin the debate in their favor, I think. So I would be fascinated to hear what is conscience today in people's mind. I mean, I don't know anymore.
Throw it open.
One sort of very basic view of it is that it's just this one philosopher calls it our inner nag. So our conscience is our inner nag. It's this voice inside our head that nags us into doing what we think is morally right and threatens us with guilt or shame if we do the opposite. So it's tied up quite a bit with guilt, with shame. And it says sort of tisk tisk, if you do that, you're going to feel horrible about yourself.
Well, that's a negative approach. See, conscience can praise as well as blame. And first of all, let's be clear on that. You're right, that nag thing. Yeah. But conscience can say, you've done good. That's not being proud either. That's a very positive thing. I did well. Whatever it was, that deep peace. So that's the first thing I would say. Conscience can praise as well as blame. So two sides to that.
Yeah.
The factor you brought up here about consciousness and conscience. Well, you got to be careful now, because conscience is an activity of our intellect and our will. And it's the practical intellect, getting technical now, deciding what you can do or not do based on some objectivity now. So that comes at what you were alluding to, this whole subjective notion of conscience, which we're infected with culturally. We're infected with relativism, we're infected with who are you to tell me what to do, we're infected with, I want to do what I want. That's the world in which we live. However, our whole system of law, and even the United Nations Charter of Rights, is based on something bigger than the individual. So right away, I would argue that there are some objective norms, standards, reality that we have to look at when we're forming our conscience. It's not just what I think, to come at your point.
I think this is a really serious, this goes to how much should we value the conscience of a healthcare professional? Do we think that the values that are driving them are objective or just purely subjective? Purely subjective, they're just their own personal values and they're not necessarily right. Or are they the right values? So you've got a question from that, and then another one.
So my question is a follow-up to exactly this discussion. I'm curious, it strikes me that the way you've just characterized the dispute is a bit misleading, because it's not as though on the one hand you have people who are saying, it's all relative, and because of this, abortion is permissible. And and on the other hand, it's like, no, abortion is objectively wrong. Because I would imagine that people on both sides of the debate, if you think that abortion is permissible, you think this is a moral truth, and furthermore, that a doctor is obliged to perform an impermissible act if they have no good moral grounds to object. So so I'm wondering then, and surely you believe that we have an obligation to do what is right. The debate is then over what's the right thing to do.
I guess I would just counter that too and say what's the right thing to do for whom. So I don't have, if I'm providing a service, I don't have to receive that service. I'm providing that service. So it's, I think in a lot of the context we're talking about, what's the right thing? I don't think that in order to provide a service, you have to believe it's the right thing to do. I think you have to believe it's the right thing for that person. I don't think you have to believe it's the right thing for that person, but you need to be able to open your perception to think it's possible that it's the right choice for that person.
My comment was around the same. I had the same kinds of thoughts. I'm a nurse, and in nursing we're taught that it's the patient's conscience that matters, and our conscience tells us that we have to facilitate and support. When we develop a therapeutic relationship with a patient, it's their conscience that matters. And that allows us to work with people from different cultures and different religions, because we're looking at what their conscience is. And I think we've kind of lost that in the discussion tonight. Why is the healthcare provider's conscience more important than the recipient's conscience?
Do you think that's a good point? And I mean, our subtitle for the discussion tonight was conflicts of conscience in medicine. And the conflicts could be between, the professional and the patient. They both have a conscience that's directing them in a certain way, but there's a conflict. The conflict is between them. I think that's a good. Does anyone want to?
I just want to say that I think there's a huge difference between acknowledging or respecting healthcare professionals' conscience and also respecting patients. So there's a difference in terms of conscientious. There's a difference between a healthcare professional saying, I won't perform this procedure because it's against my conscience, and also saying, but I won't allow you to have it done either, or to impose your own beliefs on the patient. So it's about respecting both the healthcare professional and the patient where there's a choice. And there's not always a choice in this country, and that's where I think the conflict comes in.
And I think we need to respect, too, that healthcare providers do have power. If I'm choosing to give people misinformation based on my values and beliefs, or if I'm limiting their access, the only way they have access is through me. And if they could access it on their own, they would just go and do it. But I am in that position of power, and recognizing that and limiting that power and giving some of that power back to the individual, allowing them to make healthcare decisions that are appropriate for them, regardless of whether I choose to agree or disagree morally with what they've chosen, and not then holding them accountable to my standard, but holding them accountable to their own standard. And I think that that's important as well.
Just another thing to throw into the debate is the point that healthcare professionals have a monopoly. It's given to them by the state. They're self-regulating. They control who's in, who's out. That has obvious financial implications, all kinds of other implications that benefit the members of the craft. It's also about protecting the public, but it's also about protecting the union. I'm using that term loosely. But when you are given a monopoly by the state, you have to accept that there are then going to be limits on what you can do, and the price of the monopoly is sometimes that you do things that you don't agree with. And I think we lose sight of that fact in the context of healthcare in Canada in particular, where it's a publicly funded system. People have a very, very important, very powerful monopolies inside the professions, and we can reasonably demand of them that they do certain things. And the other piece related to that is that when institutions are publicly funded, I think that changes what their obligations are.
So when you have a hospital, the olden days, you had a hospital that was completely funded by the church. And there were 2 hospitals in every town, 2 or more, right? You had the church one and the non-church one. Well, then it's a different kettle of fish when you're talking about what that church-based hospital has to do. But when you move into all the hospitals being funded by the public system, you then don't get, I think, to say, we don't want to do these kinds of, especially where nobody in the town will then do it. It's one thing to say, we're going to divvy up, we have concerns about this, well, but this institution is perfectly happy to do it, we'd like to not do it, we make that arrangement, everybody has access, that's one thing. But when you don't have access, and you're fully publicly funded, and or in the context of the professions, you're inside a monopoly, those are social goods that create responsibilities that may be for engaging in conduct that you find personally problematic, and then you go back to your exit option.
You make a very good point about Canada vis-a-vis the United States, because that is true. Our system here is quite different, and for faith-based hospitals here in Canada, we own the property, shall we say, but we don't own the services. Of course, in Canada, sisters, pay tribute to them in spades brought healthcare in Canada. That's just fact. And they work for nothing. Religious sisters, we just have to say that. However, things have changed now. Sisters moved off the stage. Now we have Catholic hospitals, but no longer are the sisters there. It's a whole different thing. And maybe in our country, it's the end of faith-based hospitals. That could be. That's a whole other kettle of fish, where are we at? But that's one dimension of where this argument could lead us. If there is no corporate conscience, no conscientious objection, in a sense to think we don't agree to, one system, it's up to each individual now to choose what to do. Well, that is an option.
With regard to conscience, as I see it, I think each person has their conscience, and that if I'm providing a service, I have to respect the other's conscience, but I also have to respect my own conscience, and I can't abdicate my conscience because I'm in a position to provide a service. So I still have to follow my own conscience, I would see, because it's absolutely crucial. The other thing, doing no harm, if that's a basic principle, which I think it is, if I'm convinced, and along with many others, that doing a particular procedure is doing harm to someone, for example, abortion, or euthanasia, or providing particular services, other services, then first of all, I would be obliged not to do it. And if I am convinced that it is harmful for our society, that it's undoing the fabric of our society, then I would see that I would have responsibilities for working in ways so that that harm is not done, is not expanded, but really is somehow removed from the society. So in terms of conscience, it's not only a personal thing, but it also has social ramifications. And so I just can't privatize my conscience nor my actions.
Yeah, I think we all need to think about, no matter what our moral beliefs are, our politics, try to imagine a request the patient would make of you that you just don't feel that you could honor. You might say you're a reproductive endocrinologist, you do fertility treatment, and you've got a patient who wants to do an 11th round of in vitro fertilization, and you just want to say, no, I think that would be harmful to you, and I'm not going to do it. So, I mean, are there, maybe I'll take it back to the, I don't know if you're a nurse, but you're a nurse. Take it back to the nurses over here. I mean, is there anything that a patient would request that's legal that you just would feel like, I can't do this? That nurses should do whatever their patients request of them. Actually, nurses have quite a well-developed policy on conscientious refusal, and it's I think they have the best policy of any profession. It's about 4 pages long, single-spaced. It's certainly the most substantial policy I've seen, the Canadian Nurses Association. And I can't remember the details of this long policy, but it does give some room for refusal. But it gives room for refusal, but I'm pretty sure says that, they can't cause any delay in the patient's care. They have to make sure there's somebody who.
I think it relates to Robin's point about you choose then to work in a place where you're not going to be called upon to feel that way. I think that's part of what we do for conscientious objection. But no, our whole training and belief system in nursing is that the client is more important, I guess, than we are in some ways, and we are a conduit for them to achieve what they need to achieve to reach health.
Can I pitch a question? Can I just pitch a question back to you? Because I can see the argument that if I believe something's wrong in the system, it's legal, but I think it's wrong to do, I should fight to change the system. So I stay with it, I am within it, but I lobby to change the law, I'm working to change policy and so on. The piece I get stuck on is the notion that I don't provide the care that's legal, that the patient wants, that is consistent with good care and so on. It's just I think it's immoral. And I'd ask what you would do with, and I think Robin may raise this example, of a Jehovah's Witness surgeon who says, I don't believe in blood transfusion, so I'm just not going to give blood transfusions. Because the push is to sort of see whether we're privileging certain kinds of conscientious beliefs, where if they're considered out there, because in Canadian society, the Jehovah's Witness belief that blood is wrong is considered pretty out there and is really very easily dismissed, versus the notion of pro-life is not easily dismissed. And so people are more hesitant about suggesting you should trod on that kind of conscientious belief than they would be about blood. So what would you do with, is it okay for the Jehovah's Witness surgeon to say, no, I'm doing surgery, but I'm not giving blood because I believe it's moral?
Ultimately, he would have to follow his conscience. If he was, or she, was absolutely convinced that that was immoral, then they have to follow their conscience. So ultimately, you can't violate your conscience.
Should they be allowed to practice surgery, or should we say, no, you have a duty as a surgeon to give blood, and so if you're not prepared, then fine, leave surgery, but you can't be a surgeon and not provide. So we say there's a duty to provide this range.
That's a further question.
He's in the wrong field, I'd say, period. Thing is, in terms of something about providing blood, that's good medical practice, and it's definitely for the health of the woman or the person needing the transfusion. To take a bite is a different thing.
But not in the opinion of the Jehovah's Witness doctor. It is not in her interest to receive blood. It's directly. So we readily say, well, get out of being a surgeon. So why do we not as readily say, well, get out of being an OBGYN? It's good medical care. In many people's opinion, as far as the Canadian government is we're concerned, it's medically necessary service. It's good medical care, and it's in her interests, just not in that person's opinion. So we say to the surgeon, get out.
I think what's missing is evidence. A lot of what we do as nurses and healthcare providers is evidence-based. And I'm not suggesting that there isn't evidence in terms of spirituality, but certainly I can tell you conclusively that if a person's bleeding out, that giving them blood is going to save their life, right? Spiritually, I'm making a judgment call on them that I believe, based on my values, that in doing this, I'm going to cause you more spiritual harm. But your belief system and my belief system are not necessarily the same. So now I am having to live by your belief system, where I could potentially die by not getting blood because your belief system says that now I potentially could be going to hell. I have no idea what the belief system is. I'm throwing that out. And so my soul is worth more in that person's mind than my physical life, whereas I might have completely different values and beliefs. So where's the evidence to support what we're doing medically? And is there evidence spiritually? Like where do you get your rationale, or is it, do you know what I mean? And there needs to be discourse with the individual, because having one person make that decision for somebody else is not fair.
Maybe you should have to disclose that to the patient, so that the patient, you tell the patient, I am Jehovah's Witness, and I may operate on you, and you may need blood, but I won't give it to you. You still want me to operate on you? And the patient has a right to choose, and I would bloody well choose no. I mean, we have good evidence-based medicine that blood saves lives, especially with hypertension.
I think ultimately the example wouldn't bear very long. It would be a short-lived surgical career. So
exactly.
One of the things, just keeping with what Jocelyn was talking about, I want to throw sort of two questions out to the audience. One being, we talked about, we have a public health care system. Some might say arguably, but we have a public health care system, and I would say my training is combined, owned by the banks of Canada and the government of Canada, so they pretty much own me between the two of them. So should then maybe our admission criteria to medical school be that should we only, if there's a need in our country for providers, and our country has said this is an acceptable service to be provided, then should that be a criteria for admission? Does there need to be 70% of people admitted that to medical schools that are willing to provide a service, and they have to agree to provide that service starting out? So that's one question. My other question would be, is fear of threat consistent with conscientious refusal? So I do know a lot of people who say the reason they don't provide a service is because they're fearful for their own life or the lives of their family. I know people who did provide services had children in stock. So does that fall into this category? Is that another category altogether? And I don't know the answers to that.
Hi. Yeah, my question is about the next generation of doctors. Are they going through the curriculum and being exposed to this to form their own conscience? Here in Canada, we'll limit the debate to here in Canada. Are they getting the proper training? They may not, I'd say they get the technical mastery, but to make those decisions in medicine have ethical and moral implications. Do you think that they're receiving the training that they need? Or are there huge flaws or just minor tweaks that need to be made in the system that we have now?
I think that they get training in what their duty is and in what their rights are. But I don't think we have conscientious training. I don't think that there's an attempt to govern the morals of people to a certain extent. However, you can't get kicked out of medical school if you have, you can't earn your spending money in certain professions on the weekend. That's not allowed. Well, you can get kicked out of medical school for anything that's deemed immoral, and most medicals do have a moral committee, but they're rarely invoked.
And I've had medical students talk to me about their inability to get training in abortion. So there's one issue is how are we training them with respect to being able to analyze situations of conflicts of conscience and understanding what to do and what their rights and obligations are. Another side of it is, though, that conscience is surfacing at the level of education in terms of both institutions saying we're not providing training in this, and students saying I don't want to be trained in this, and can we say you cannot graduate without learning how to do this, if for no other reason than the fact of an emergency situation. Because most people will accept emergency exception that you can't conscientiously refuse your way out of somebody's dying because you're not doing it. So what's going on with that? And there's a group called Medical Students for Life, and they're quite active, and they're very frustrated with the situation with medical education in Canada right now, around specifically, not around blood transfusions and things like that, but specifically around abortion.
You mean Medical Students for Choice?
Yes. No, there is
Students for Choice.
Yeah.
Sorry.
There may
always, I'm sure there is a Medical Students for Life too.
Medical Students for Life. Yes.
I just wanted to raise one point, just throw another point into the mix here. This relates to Robin's point about putting restrictions on admission to medical school. One worry about restrictions like that, and putting restrictions on institutions too, is just that we may not have the healthcare providers that we need because people decide I'm not going to become a healthcare provider because I won't be able to listen to my conscience and obey it. I think at one point in time, and I'm sure this is still true, that the biggest healthcare provider in the world is the Catholic Church, I'm pretty sure. Worldwide, the biggest provider of healthcare is the Catholic Church. So if we say, no hospital, no matter whether it's a Catholic hospital or not, can make conscientious objections, assuming this institutional conscience thing makes sense. We have to worry about what the consequences of that will be. Even if we, disagree with conscientious objection, we still have to think about the consequences. So I'm throwing that out, but I think there's a point back here.
If I can speak to your second question about what about a case where a person fears for their family. I think that in that situation, it just have to be the case that a person will have to choose between their job and their fear for their family, because there are many professions that are necessary, where if a person was always choosing their family, then their job just would lose meaning, like police officers or politicians who said, I can't do this because I would be afraid of my family. The system of law would go to hell very quickly, and it wouldn't allow for any faith in the system at all. So on that basis, I think it's just one of those situations where in the medical profession you have to choose. You can't do both, because you can't, as a system, allow that.
Did everyone hear that point? Do you mind reformulating, or just? Sorry, I couldn't hear the entire.
Let's see if I get this right. That you don't want to allow people to opt out but stay in the job on the grounds of fear for family, because otherwise there may be all kinds of other circumstances when people would do that and our system will fall apart. So if you look at police officers, and you just can't just say, well, I just want a safe beat, or politicians. So you either choose your job or you choose your family, but you can't use that as a basis. Can I use that as a launching point to it's a different point, which is to say, you know what, a lot of the time what we have to do is actually, you won't like this, say stop talking about the debate about conscientious refusal, but to say, are there other ways to deal with some of these problems? So for instance, if it's about fear, and there's a legitimate concern about fear, in as much as it's legitimate, we address it by protecting providers. We have bubble laws around clinics. We have really harsh treatment of people who harass providers, all those kinds of things. We can protect providers. A different kind of example, another example of your issue, do we accept people in only if they do? I'd turn it around and go back to your debt issue and say create incentives. If we have a shortfall of providers, say abortion providers, we don't have a shortfall of surgeons, but so we don't have to worry about getting the jobs with them. But if we have a shortfall of abortion providers, we know we have people graduating with extraordinary amounts of debt. This is something we need. You do forgivable loans on the basis of, will you provide? Just as we say, if you'll go to a northern community, if you go to this, that, and the other community where we need nurses, doctors, various things. We will back end debt relief. Right? So you go through. We're not locking you into a contract and saying, sign on the dotted line. We're only letting you in if you will do this, because that's a disaster. So they change their mind, and then what do you do? But you say, I'm prepared. I will be an abortion provider. Well, I say, as long as you're an abortion provider, every month we forgive some of your loan, because what we're saying is, we as a society believe women should have access to these services, and that's how we will do it. So a lot around abortion, we may be able to resolve a bit by being creative and saying we do want to respect conscience. There is something valuable in conscience. So are there ways in which we can do it without the harm? Because the justification for violating freedom of conscience is a concern about harm to others. So one way is saying, okay, we violate because there's harm to others. Or we say, well, are there other ways to mitigate these harms? And we may be able to do that with faith-based institutions if we can negotiate. So the other institution a block away says, yeah, we'll take these things on, and then the other institution says, so we don't feel compromised. Okay, then you've both got the conscience staying fine, and you've avoided the harm. In which case, you don't have any need to limit the conscience. So we have to get creative.
With that, because it piggybacks on what you said about the church and what we provided over the centuries, literally. Right? In the sense that I'm 70, going along this planet, thinking to myself, I'm getting to the point now where I start to use up the healthcare system. They say the last part of your life, that's when you use up all the money that you put in all your life. Let's try to stay healthy. I jog every day practically, keep alive and well. Okay. But the sisters have moved off the stage more or less. The state's a little different. The orders are growing, some of them, the religious orders. But I've made this statement several times, with the growing senior population, the needs, can't afford it, etc., etc. I'm wondering if we don't need some new religious orders now who are going to come up and say, Father will look after you. Homes for seniors, the Vanier homes for mentally handicapped, which is a class act, by the way the Marsh homes work for the mentally ill. Wonderful. And I don't know if we need more of these to spring up. And that's been the tradition of the church. When there's been a need, a Mother Teresa appears. That's what happened. And we're talking centuries now. That's a wonderful thing. So I like your idea. Maybe we're going to have to. What's new? Waiting for us. Good point.
Anybody else have something they want to add in?
So Robin asked a really interesting question earlier about whether there should be some sort of inquiry into people's moral beliefs, and you also mentioned about physicians could avoid conflicts of conscience by not going into certain areas. So I know a physician who was denied an MD at the University of Manitoba because it was well known that he was an evangelical Christian, and he was asked several weeks before graduation whether or not he would refer women for abortion, considering that it was well known that he would never perform one, and he said no. And the medical school made the decision not to grant him an MD. So he sued the medical school, and they settled outside of court, and he was eventually granted an MD. But it goes to show that there has at least been one example of somebody who was inquired inquired into his moral beliefs, which seems to me, I wonder for Jocelyn, if that's, it seems to me, is that a violation of freedom of religious beliefs to inquire about people's religious beliefs? That would be one question that I have. But then I also ask, I would like to know from you, Robin, having experience in medical schools, whether, is that standard? Are people asked about their moral beliefs? Do medical schools get a sense of who's going to do what ahead of time?
Well, they know who's going to do what in terms of what residency they're going to do. Do you know what sort of residency that person was doing? Because sometimes I wonder, is it relevant?
Right. I actually don't know what residency they were going to do. Eventually they went into a branch of medicine where this is not going to be an issue for them, and I don't know if this was always his intention, but he was just asked point blank, would you refer for abortions if this was... So he must have had some intention at one point. Otherwise it would be just totally arbitrary.
It could be sort of a squeaky wheel situation where I don't think They certainly didn't ask me, so they don't ask everybody graduating from medical school. I suspect it wouldn't be a normal practice, so I wonder if something might have, and I'm not saying I think asking people prying questions about their personal beliefs is the way to go. I'm just sort of wondering what people think about how to solve these problems, but that wouldn't be typical. They do hold people back for egregious moral errors. So the only people I knew that got held back in medical school, they were in criminal trouble. So.
But Jocelyn, just from a legal standpoint, is that even a possibility on the table that you could ask somebody coming into medical school, by the way, we want to know right now, would you perform an abortion or would you prefer for an abortion, or what is your position on abortion, for example? Could you ask that question of somebody?
I don't think you could do anything with the answer. So sometimes you get in trouble asking questions if there's nothing you can do with the answer. If you could frame it as discrimination, so if the person took it as potentially discrimination on the basis of religious beliefs, then you could get into trouble. There are a host of questions you can't ask on a job application, but that's grounded in this notion that you can't discriminate. Now, if you set it up that you said if we, for the sake of argument, we said you do have a duty to refer in law and through the policy, that question could relate to whether you are prepared to perform your duties. And you could make an argument that if you're not prepared to do your duties, you shouldn't be given a degree. It would be a novel argument. And I think they settled probably because of at least in part, because of the contentious nature of the question of whether there's a duty to refer. Because they probably couldn't make that argument in the sense that CMA would have come barreling up behind this person defending them, saying that there isn't a duty to refer. So if it's just you won't do something that there's some disagreement about whether it's your duty to do it or not anyway, then you're on really dodgy ground. So that's just not the way to go. I mean, the way to go is get clear on what the duties are, and then enforce that people meet their obligations. So have the tough conversations to establish what the duties are and get your policies clear, and get your statements of law clear too, because this, the other thing is the CMA can say anything they want. That doesn't create the standard of care to which a physician will be held in a court of law. The court reserves for itself the right to establish standards of care. It will look to the policies, but it's not bound by them. So the CMA can say there's no duty to treat, there's no duty to refer, and you fail to refer and a person doesn't get an abortion, is desperately ill-harmed. You could be sued for negligence, for sure, even if the CMA didn't require a duty to report, because I think a duty to refer, because I think you could find a duty to refer in Canadian law, quite a permanent policy.
Would that hold true if the pregnancy wasn't threatening to her life, but ultimately she developed preeclampsia and got very, very sick at delivery, and she said, I didn't choose to continue this pregnancy. And then, so the reason for termination was elective, but ultimately she got sick as a result of the pregnancy. Would she then have a ground to say, I didn't choose this pregnancy?
Yeah, I think she could. She'd have to argue that it was standard of care that the doctor had a duty to refer, or to provide services, but a duty to refer. And if that physician failed in that duty, and as a result she was harmed, and you show that link, then you're accountable.
What if a person was refused an abortion by a medical practitioner who didn't refer her to someone else, and she sought out a backstreet abortion and was irredeemably harmed by that? What recourse?
The analysis you're going to have to run is, did the physician have a duty of care to her? So was it his patient? Let's assume yes. Then did that physician meet the standard of care? Then you're into the question of what are the physician's duties? And then we'd have a fight in court about whether there's a duty to refer. And different people will answer you differently as to how successful that would be. I think you would find a duty to refer. And so by failing in that, if you'd say failed to meet the standard of care, and then you have to ask the question, did that cause the harm? And you have to show that link, that the failure to refer led to the harm, and so on. So, I can't say straight out for sure, yes. Partly because it's just awfully hard to successfully sue a doctor in Canada. The malpractice crisis is a myth. A myth. You will be sued. Absolutely, you'll be sued, but you won't be successfully sued. So that's why I hesitate in saying, oh yeah, for sure that they'd be found liable, because you can't always. But that's the analysis you can run. And you see how it hinges on the question of, is there a duty to refer? And so we would look to the CMA policy and we'd say, what does it say? Have a fight about that. And we'd look to the common law and see, is there a duty in there?
There isn't a duty in there right now that says, you have to refer. It's kind of understood. There's sort of a norm within medicine about referral, but it doesn't say specifically make a referral, does it?
She has to be able to get to treatment without delay. You can't not stop treating without that transfer. And so that's the other thing, is if there were others available and she, you said, look, go next door, and the woman didn't and chose to go somewhere else, that's a different case. But if, say, the person just said, I'm not talking to you anymore, I object to this, I'm not helping you in any way, and she was in a place where there wasn't any way for her to get anybody else, I think you're in trouble with it because of the piece of the policy that says you can't cause delay. Well, that's the ultimate delay, is you never get to you never get to a Robin, you get to a backstreet abortionist.
Yeah, it's just sort of interesting how that referral language isn't in there. But yeah.
My experience in this regard is decades old, and I was in a position where I was talking to people who were frightened and seeking abortions, and they weren't people who would respond aggressively if they were sloughed off. They didn't know what to do. I wondered in the interim over the years what really was the situation. What's the situation now? Is there still really not sure? The whole thing of duty of care is not straightened out. That there's no law about that. It's still a question.
The years ago piece is, though, that it was illegal.
Well,
right?
It wasn't
prohibited
illegal.
under the
It wasn't
criminal
illegal
code.
then. There were committees in hospitals.
Oh, so we're into the committees, but the committees caused such extraordinary delays that women, and there were hospitals that didn't have committees. There were hospitals whose committees met once every 6 months. So it really wasn't available. So I don't want to leave you with the sense that the duty of care, what the duty of care is being fought right now. The analysis the court would use is clear, and it would march through its steps. But
then there were young kids who were frightened and unsure of their rights, and there were people who didn't have good English language skills, who might be visitors here, going to school. They're really scared about what had happened to them and what they would do.
And we still have a lot of those problems. That is a key point. Is people think that access is fine. The providers think that access is fine, but access is fine for the privileged, and that's why it's perfectly fine for any provider. Any female provider who needs access to abortion has one. I teach the law students. They all, and I say to them, You're all privileged. You all have access. So you're not fighting this battle because it doesn't seem like a battle to you because it's available to you. But you're this percent of the population, and it is not available for huge numbers of women, and it's the vulnerable women.
And I just want to add to that in the situation I'm familiar with, which is the Maritime Provinces, it's not available, and the responsibility is being shrugged by the providers to say, well, there's a Morgan Health Clinic. So, and that seems a reasonable option. There's access. I've heard so many people say, there's access. You can go to so in New Brunswick, the only access is a Morgan Health Clinic that's centrally located in the province. They're small provinces, but if you're 16 and trying to not have your parents find out, it's kind of hard to explain your trip to Fredericton and how you got $700. And it's even worse. So in the situation on PEI, I believe there's still a court case going on where Morgan Heller was successful in being allowed to open a clinic, but then never did. And providers almost have the opinion of, well, why doesn't he just open up a clinic? So it's almost like it's not my problem, it's not my job, it's somebody else's job, and I don't feel any sense of responsibility towards that.
All right, comment over here. My mic was off.
Okay. I just wanted to sort of revisit, the notion of the next generation of doctors. I myself am going through the whole application process to medical schools, and so I think that nowadays we're sort of taught to look at every side of an argument, and even if we don't agree with a certain position, we have to respect all positions. Everyone here, I think we all respect the different positions, and we're debating them very well. But just I guess to give an example, so I'm preparing for interviews now, and a lot of the interview styles are case-based scenarios. I know Dalhousie is like that, and one of the cases that I've seen and had to prepare for is one where I am a physician, and a woman comes to me and requests that I do an abortion. And the case specifically says that I am not comfortable doing the abortion, so what do I do? And, I feel like in an interview, I could very easily get that case. And if I said I refuse to refer her to anybody, then, I wouldn't get a position in that medical school. And I think that's the wrong way to answer it. So I think the next generation of doctors are very much trained or taught to believe that, we do have our own morals and our own beliefs, but that shouldn't get in the way of treating a patient. And so in the case where I'm a physician that doesn't believe in abortion, then I should refer my patient to somebody that does. And so I think that's pretty interesting.
Any comments? One thing about the referral requirement is, obviously in all situations a physician can't provide a referral. In a rural situation, there's no referral to be made, at least not one that's not going to cause a significant delay. So what if they add into your case, and you're living in Fort Francis or something? What do you say to that? Saying, well, the solution to this is make a referral requirement. I think it's more complicated than that. And also there are other possibilities than referral. The one woman over here suggested, making it very clear what my beliefs are. What about posting a sign, and saying I don't do these things and list them? Is that appropriate? Is that enough? Should there also be, if it's abortion, well, I won't, participate in abortions, but I'll give you the, number for Planned Parenthood or something, and that's on the sign. Is that enough? Or should the healthcare provider actually have to interact with the patient? Maybe it would be a good thing if the patient didn't interact with that healthcare provider and didn't hear the objection. I think it was Robin who said, this could cause harm just experiencing this objection. This person in power, this person who has all this education is telling me basically, saying I'm making an immoral request. So maybe it'd be better not, to be face-to-face with that person. So is that a better solution, a publicity requirement? Have a big sign. Apparently there was a big sign like that on I think it was a walk-in clinic on Oxford Street. They had a big sign. One of my students told me about this. I've never seen it, but a sign saying we don't provide abortion services. I don't know if it included contraception too, but do you want to? What would you do in the medical school interview if it?
Well, I mean, like that, it's also come up. It's especially in a rural setting when you're sort of, you could be the only doctor serving a community of 2,000 people, and I guess in that situation, somebody comes up to you, and it doesn't even have to be an abortion. It could be something else that you're not comfortable doing, but if it's detrimental to the patient's health that they don't receive this service, and there's nobody else that can help them, then I think, to me, the correct answer is you don't have a choice. You have to help the patient, because, it's very much patient-based care nowadays, and patient-centered care. And I mean, it's always been patient-centered, but especially now, the visit, I think, or I've been taught that the physician-patient relationship is very much based on what the patient thinks is best for themselves, and you sort of, sometimes you're in a position where you might not agree with the patient, but you have to do what's right for them. And I think nowadays that's what people are being taught is the right thing to do. I don't know what the law says about that in certain areas, but I think that's what medical school interviewers are looking for anyways.
Looking at that scenario realistically, like I work in a birth control clinic just down the street. People come in for referrals for abortions. Really, if we had nobody to refer to, we're not going to be doing abortions in our clinic. We don't have the setup, we don't have anesthesia, we don't have the capacity. So just because you're the only doctor around, you might be a GP and you might not be qualified. I mean, that's the reality. The referral process is still a huge component because you can't be and do everything for everybody. So I think realistically, referral is still a huge portion of what's going to get done.
No? Come on, Maggie. I'm making you stand up in front of everyone.
So I was just wondering, we're talking a lot about referrals as sort of an answer to conscientious refusals, but presumably the people who are conscientiously refusing feel, rather strongly that what's happening is an immoral act. So is a referral for them an acceptable answer?
What I've been thinking is, as the discussion been going in the last half hour, in a way, it does connect with what you're saying. And so how can I say this and really offer some hope? And the new students, I call you new, and this young man here, are there other options? What you're saying. And in our culture, what are the options for women when you get pregnant? And what hope do we give them to bring that pregnancy to term? A baby's a baby. It's a positive. A child is a positive. Can we think positive in terms of the options here? What is being done in other centers to help these women who have perhaps been forced into this pregnancy? It's unfortunate for the woman now thinking, heck, we have a baby, we have a child, human being. Are there other options here? I just think that all of a sudden the whole tone of our night is all of a sudden kind of descended in a way. Like, well, we got to defend abortion. And I don't think anybody really wants to say that. I think that's what the purpose of tonight is. It's that there's a real dilemma here. How do we help people in these difficult areas? Respecting religious conviction, respecting what a woman wants, and yet also respecting a deep value big to get to the abortion issue. So your question is saying, referral, is that the only way? I picked the wrong spin on it. Are there other possibilities here? Think outside the envelope again for this real situation we're in.
But I think Maggie was worried about, her name's Maggie, for those who believe that, this is a very deep value, important value, and that is of human life, unborn life, is a referral going to be acceptable, right? I mean, if you have that belief, you're gonna think that abortion is murder. And giving a referral is just like, telling a murderer or someone who wants to murder someone, I'll help you do that, right? Even though I might not commit the act myself. And we would tend to think, if it was a murder of a born human being, we would think that's just a horrible thing to do, to be complicit in that act of murder. And so some people who believe very strongly about physicians' rights to conscientious objection will say that referral is not the solution because it just makes these objectors complicit in an act they find very offensive. And it's really not, some will say it's really no better than forcing me to do it myself. So this is a worry about referral. I mean, some people think it just sort of, it makes the objector no longer responsible. But that's not clear, that they're no longer responsible because they're facilitating something, right? Now, I'm not saying that we should abolish a referral requirement, but this is, I think, deeply controversial, that particular requirement, yeah.
I wonder if it's possible to expand the notion of referral. Like, could there be referral to other things like adoption, to other possibilities of accompanying the person, and perhaps abortion isn't the only option that's possible. So when we use the term referral, I wonder if we're not using it in a very restricted term sense. And perhaps somebody who has difficulties in conscience from doing an abortion perhaps could do a referral, but to something else other than abortion.
What? Sorry.
I think generally the referral, at least in my clinical environment, the referral is to a center that counsels on all of the options. The problem being the person making the referral doesn't want to refer if one of the options is abortion. So they're not willing to have that option discussed, despite the fact that they will also be counseled on open and closed adoption, and they'll also be counseled on contraception. Well, they get a lot of counseling, a lot of very good counseling, but the objection is to letting them be counseled at all on terminating the pregnancy.
Okay, let's take one more. We're actually over time. I'm surprised. I was going to end things at 9. It's past 9. So we'll take another comment and wrap things up.
I would just like to say well done to the two nurses, because I think that they've got the nub of the issue here, that any moral dilemma, the paramount one is with the patient, not with the person providing the service. That's secondary.
Do you want to make any final remarks related to that, or just?
That's great.
Well, just piggyback on the nurses too. We've already paid tribute to their code of ethics, which is very well done. And your opening question, the CMA, well, take a look at what's in their code of ethics. You hinted at that, when you said that, and I do pay tribute to what's there. Little I know of it, it's well done, and to me, it's defensible. But it doesn't contradict the things that we talked about, respecting the religious values of people.
Yeah. As far as I can tell, the CMA doesn't have anything that's near as clear laid out as the CNA, the Canadian Nurses Association, does. So that's what we've been discussing tonight is, they need to come up with something. I think that's true, and the issue is just what should it be? And I think you've seen that this issue it's very difficult. I'm not sure I want to be the one coming up with this policy, but I will certainly convey our thoughts and ideas to anyone who does try to come up with it. So thank you for coming out. And as I mentioned, if you have ideas for further cafes, please write them down on the sheet over there and give us your email if you'd like to be invited to a cafe in the future. And please take home cake, because there's lots of cake. Thank you, everyone, and have a good evening.